We are recording. It will be available on daughterhood.org. It will also be released on Thursday for my Daughterhood, the podcast on Thursday. We are going to work through questions. If you have any questions that you want Dr. Zitter to address, you can put them in the chat. Susan Rowe and Robert Chalet will be monitoring the chat. I am Rosanne Corcoran, host, creator, and producer of Daughterhood, the podcast. I want to thank you all for being here today for this special event. I'm more than thrilled to have Dr. Jessica Zitter as my guest today. Dr. Zitter is a strong advocate for a new approach to caring for the dying. She specializes in critical care and palliative care medicine and practices at a public hospital in Northern California. Dr. Zitter's first book, Extreme Measures: Finding a Better Path to the End of Life, offers an insider's view of intensive care in America and its impact on how we die. Her essays and articles have appeared in the New York Times, The Atlantic, Time Magazine, and the Journal of the American Medical Association, among others. She's also been featured on Fresh Air with Terry Gross, The Doctors, Dr. Oz, and CBS This Morning. Her Oscar-nominated film Extremis is available to stream on Netflix, and her most recent film, Caregiver, A Love Story, challenges viewers to acknowledge the difficult challenges facing family caregivers and to envision a new approach. Her website, jessicazitter.com, is the most comprehensive resource on end-of-life care. I'm so happy she could join me today to answer your questions. It's always a thrill anytime I'm able to speak to her. Welcome, Dr. Jessica Zitter.
Oh, so good to be here with you, as always.
Always great to see you. Thank you. I've spoken to so many people and, through personal contacts in groups, even the posts I see online. And when it comes to someone's last minutes, hours, days, even that whole process, I haven't seen one person who didn't feel like they had some sort of wrongdoing or misdoing or responsibility for their loved one's death and the death process. The responsibility that's left in the room with the caregivers is just incredibly hard. How do we make that better? How do we try to bring, is it education? Is it training? Do you think people want to know that their loved ones are dying? How do we do this, Jess?
Oh, wow. This is such a multifactorial problem. We don't do dying well in America, whether it's inside of the hospital or outside of the hospital. We have this sort of process that I call the end-of-life conveyor belt, where most people, sort of the default approach to most people who have serious illness or who are approaching the end of life, is to bring them into what I call the end-of-life conveyor belt, just to keep this high-level, life-prolonging intervention system going to try to keep this body alive. And it's people who actively opt out of that system who have the opportunity to go home and use hospice, or to go home and have be with family. That requires opting out, because it's very hard to get there if you're not actively planning for it. So when you talk about extremis, these people are, the message of that film is, think about the ICU as a destination that you may not actually want to go to. And if so, back it up and make some advanced care plans. And the same thing for Caregiver, A Love Story. The whole system really needs to be planned for in advance. But the last thing I'll say, it's too long an answer for you, but we don't support caregivers in the outside world to do the job that they need to do. We don't support them financially. We don't support them with training. We don't support them with the kinds of things that a person needs to do this work, as you well know. And in the hospital, we don't support physicians and patients and family members to make decisions that are more patient-centered around issues in the intensive care unit or in the hospital. So we've got a lot of supporting to do, whether it's financial, teaching, training. There's a whole variety of things that we need to do differently. Long answer, sorry.
No, that's great. I love it. And opting out then becomes feeling like you're giving up because of that H word. Once hospice comes in, everybody thinks, well, we're giving up.
Yeah. We've really, in America, it's not only the physicians and healthcare providers who have been trained that there's always something else to do. There's always some other intervention to to reach for. But family members and patients expect us to be doing that. So this almost what I would call like a collusion, this belief that we just have some answers that we often don't have. And so instead of really sitting down, looking at the situation, looking at the prognosis, looking at the reality, we just keep doing things, and we're just avoiding this very, very, very important reality, this existential reality that we are all going to die, and we want to do it in a way that works for us.
Right. And I think one of the underlying factors is choosing hospice or choosing not doing the intensive treatment. It
Right.
almost feels like we are doing something to them, when in reality, they're dying.
Yeah.
And we have to step back and look at the fact that they're dying, and we need to try to help that process.
When I describe hospice to people, because hospice has a marketing problem. Hospice is, the giving up, the death word, the weak doctors, the the abandoning of the patient. When I describe hospice to families and patients, I say, have you ever heard of hospice? And a lot of times like, oh yeah, well, we don't want hospice. And we sit down and actually talk about what hospice really is, which is wrapping an extra layer of support around a family, around a patient, to allow them to be in a location that they would want to be in, which is for most people home.
Right.
It's adding. It's the opposite of abandoning. It's adding on all sorts of things, and people most of the time go, oh, and often end up choosing hospice when they understand what it really is,
Right.
And what it's not, by the way.
Well, I was just going to say there's a certain level of expectation that comes with hospice.
Yes.
So when you choose hospice and then you're under the impression that somebody's going to be here all the time, that's not what hospice is.
Very true.
And then there are things that you need to do that you didn't realize you signed up for. And then that comfort pack comes to the front door. And when you stop sweating and thinking about what is in this comfort pack, what do you do? And there's a reason they send a comfort pack to your house. What is that? How did that come to be? Because there's a lot of drugs in there, Jessica, that make people very uncomfortable. And we can talk about the specifics, but where did the advent of sending this comfort kit home come from?
Well, it's interesting that you say that, because I don't actually know what a comfort pack is, and probably many people on this call are hospice people or caregivers who've experienced hospice, but I don't know what it is. I'm assuming it's morphine, and it's depending on the illness. It might be black towels if someone has the potential to have a bleeding event. I don't know what else is in it.
It's morphine, Ativan, Haldol,
yeah,
Tylenol suppositories, something for nausea, regular Tylenol. I can't remember the rest, but
right.
They're pretty heavy hitters, and the morphine alone makes it very uncomfortable. People
have a lot of associations with morphine.
Yes.
So the thing I think that we really need to be clear about, let's just talk about that issue. What is hospice not? Hospice is an amazing service that allows people, like in our film for Bambi, to actually be at home when they otherwise might not have been able to be at home. It provides all sorts of durable medical equipment. It provides the comfort pack, all sorts of medications that might be necessary for somebody who is really having serious and end-of-life illness. All the things that are you would not want to be at home without if you are coming to the end of your life from a chronic or serious illness. What people need to understand is that they are provided this medication most of the time. Much of the time there will be a nurse who's helping to administer, but a lot of the time the family is going to have to step up and administer these things. And that is the way hospice works. Hospice does not have a 24/7 helping with household duties, helping with hygiene and baths and changing diapers. Those are things that still fall to the family. And it's not because hospice isn't doing a good job. It's because that's not what hospice is compensated to do. They don't have the time to attend to all of the needs of the family caregiver. And what I've learned, is we in the palliative care movement used to say, oh, hospice is, once you get, decide that you're going to do hospice, that's the end of the game. We've, gotten everything set up. And the fact is, I've learned through making that outside of the hospital, what's happening is not that hospice is itself slam dunk. You have to really support the caregivers who are doing the bulk of the work. You have to prepare them for the fact that they're going to be doing the bulk of the work. You have to support them to do that. You ideally have a country that has a support system that provides for them to get in-home support from other people, professional caregivers. You have professional caregivers who are available in a pool of professional caregivers, but right now that workforce has shrunk because this is a very difficult job which does not get paid very well. So we've got a lot of things that we need to do better to support the caregivers to work alongside hospice to provide the support to the patient. But caregivers need to understand that hospice does one piece of this, and they, the family, are going to be responsible for another very large piece of it as well.
Right. Which is part of the challenge, because things can change very quickly. When you're at that stage, when you're at end of life, things can change very quickly. And as caregivers, I'm not trained as a critical care doctor. I mean, so all of that, there's anxiety, there's frustration, there's panic, really. And you don't know what's happening, which adds to the stress. And I know when the doctor said, give your mother morphine, it was a come to Jesus for me, Jess, because I thought, I'm going to give her this medicine because of everything that I've heard, it's going to kill her. Yeah. And I'm going to kill her when I give her this.
Right. So let's talk about that.
Yes.
Very important point.
Yes.
That is not true. Morphine, opioids, all sorts of other types of pain and symptom related interventions and medications. This is one of the biggest, most important things for people to understand, that if given in the way that we give them, hopefully, in search of managing the symptoms, managing the high respiratory rate if someone's short of breath, or managing the pain level if someone's having pain. If we give it and titrate it just to bring those numbers down so the person is comfortable again, morphine, opioids do not hasten death. And it's really important for people to understand that. There's just so many myths around the use of opioids that we need to really disabuse people of.
And it becomes that pass it along. Well, my friend's mother's brother used it and they died.
Yeah.
Well, were they dying? Like, was that, but in those moments, you have to decide. And part of that, on TV, we see people that are at end of death and they're sitting there having full conversations with their loved ones around them. And that's not how that happens at times. So, you think you can say, do you want this? Is this good? You're in pain. Would you like this medicine? And a lot of times you don't have that option.
Right.
But the fear is still very real.
Yeah. The caregiver really needs support to do that piece of symptom management, which is a part of being a caregiver with somebody who's having a lot of symptoms on hospice. The reality about death and dying is that death and dying are often not easy. It's not, it's not the Disney kind of fall asleep peacefully a lot of the time. Sometimes it is, and those are gifts.
Yes.
But a lot of times it's hard, and I know from personal experience, and I know a lot of people on this call probably know that dying can be difficult, and the caregiver, being that loved one, and frankly, being the surrogate at the bedside in the hospital, it's probably easier because you've got nurses and people all around, but being that caregiver in the home with somebody who's actually having symptoms can be very frightening, especially if you believe the myth that you're hastening their death. And I think what we need to do to combat that is to just be more supportive and provide more training to the caregiver so that they understand what they're doing, that they feel confident when they're doing nursing and medical duties, which is a big part of being a caregiver. 60% of caregivers actually do duties and have things that they do for patients that were once done by a nurse. That's just the reality. Mm-hmm. And we want to make sure that people are as trained and emotionally supported and physically supported with other types of support in the house, which we don't currently have, to do this work with the confidence and the calm that they deserve to have when doing the sacred work of taking care of a loved one at home. And we're not doing a good enough job of that.
Mm-mm. Well, now tell me, is dying painful? Is that why this comfort kit comes to the house?
Dying can be painful. It depends on so many of these things depend on the condition, the actual diagnosis that a person has. Not only the diagnosis, but how it's impacting the different organs, and everybody's different. Like, there's as many ways to die as there are people.
Right.
And I think it's really, really important to understand, just like in caring for patients in the hospital while we're trying to keep them alive, the same thing goes as people are dying. We really need to have patient-centered care. We need to really know how to assess their symptoms and how to best manage and treat their symptoms, and how to teach the family members how to manage those symptoms and treat those symptoms. Each patient's going to have a different set of things happening to them, and we need to really take each if hospice is involved, which is a minority of cases, but if hospice is involved, we need to make sure that the family, the patient, understand what their disease trajectory is, what all the things that could go wrong and how we would manage them are. And we need to really, and by the way, it's not just for people in hospice. We should be doing that in the outpatient clinic for people with COPD and people with, we should be explaining people, what is your illness? What are the different ways that it can go? What are the different kinds of interventions we have to try to prolong your life? What are the different interventions we have to help manage your symptoms? And really bring them into this conversation so that they're as aware as they can be about it, and as prepared for it as they can be.
But where do we get that information? I mean, on jessicazitter.com, but where do we get that information? If the doctor, you're trying to get information about the doctor and they either don't want to say it, they don't want to say, well, this is what's going to happen. Where do we get it? How do we find this?
That's probably the $20 million question, because there is a roadblock to understanding your reality. And if you are being cared for by a medical team, I'm talking particularly about doctors right now, because we are the rate limiting step to giving you the information that you need. And if you have a doctor who's not comfortable with communication, which frankly is a lot, unfortunately, way too many of us, then you may not be getting the information that you need and deserve to make plans that would be in your best interest, or what you would personally want to have happen. If you just are kind of having groups of doctors taking care of you, different subspecialties, et cetera, we're going to do this next and we're going to do that next, but you don't have it in context. You don't understand the big picture. Well, what happens if we try this but it doesn't work? Or how do we even know if it's not working? And then when do we kind of move into this mode or that mode? People are really flying blind in there, and that's why this end-of-life conveyor belt is such a trap, because it's the default approach. I'm in the hospital right now. These four walls of the hospital, the default approach is to just keep doing things, even if they're not working. So that is so I didn't answer your question, because you asked me, well, so how do you get this information?
Right.
It's the most important question. What I try to do is write articles and write books so people can get more of an insight into what might be going on with their healthcare teams, so that people are more savvy about how to talk to their healthcare teams in a way that's going to make the information come out in a more productive way. I try to make films that are that are possibly thought-provoking, not only to general audiences and kind of providing insight, but also that we can take into teaching medical audiences about how we can start to do this different. How can we change the culture of medicine so that we are all more skilled at really providing this critical information to our patients?
It's hard, because we're left as caregivers, we're left to trying to find this information. And sometimes when you bring it to the doctor, then you get did you Google it? And it's like, well, yeah, I did, because you're not giving me anything. No offense, but I got to find it somewhere. Yes. And it's a roadblock after a roadblock. And then I think that's what leaves us with oh my God, what did I do? What just happened here?
Oh, I know. And not only the, oh my God, what happened? What just happened? But the fear, panic, anxiety, and then let's not forget the financial exhaustion, the physical exhaustion, the lack of support physically. And it's, but the emotional piece that you just talked about, this guilt, what just happened? What did I do? Did I not advocate enough? Was I not a good enough daughter? Was I this? Was I that? Yes, that's the human, for a caring family member who's been thrust into the role of caregiver. who frankly didn't really have a choice. It's not like people go around saying, I want to provide care to my parent, or I want to,
Right.
you know, people, this is often a volunteer job, or it's not even necessarily volunteer. People get, as Rick says in the film, you get thrust into this role. And I really think that to be in that position, to love this person often, not always, some people don't have great relationships with the person that's the care recipient. But there is, it's and to feel like there's this perception in society that you're supposed to be a good daughter, you're supposed to be a good wife, you're supposed to love to take care. You know, the Disney version of caregiving is like that film that came out in 1970, Love Story, right? Everything, the guy sitting at the bedside of his loved
Ally McGraw.
Ally McGraw,
Yep.
sitting there, you know, at her bedside in love. Well, you know what? There were like 20 nurses around that woman.
Right.
He didn't do anything.
Right.
He wasn't changing diapers. He wasn't giving her any medications for her pain. He wasn't worrying about whether or not she ate. There was a whole staff of people around. So we've got to really figure out how to educate caregivers so that educate sounds punitive. I'm saying how to support caregivers to understand that what they're doing is a gift. It's an act of love and duty that we all as a society should appreciate and honor and hold sacred, and that everything they do is positive. Look, are there situations where caregivers might abuse a care recipient? Of course, I'm sure there are. I'm sure there are. Not the majority. And, you know, most caregivers sit with tremendous shame and anxiety and fear. And frankly, it's a reason why a lot of times people default to saying, okay, we'll just do this treatment. And so then the person gets swept onto the end of life conveyor belt. Because for caregivers, there is more of a stigma, there can be more of a stigma to doing what's perceived as less than doing more, which is always considered more interventions, more hospital, more ventilators, more tubes, and et cetera. So I think it's really important because that often doesn't go with what the patient wanted. It doesn't go with what most people say they want, which is not to be dying in a hospital.
Right. Right. And,
So-
but you have to have those conversations. You have to have those conversations. And let's be honest, nobody wants to sit here and think or call their family around and say, okay, so if I get hit by a bus next week,
Yes.
I don't want this, this, and this.
Right.
And how do you come up with those parameters? And how do you have those conversations when people are like, no, not talking about it?
Yeah. So really important point. And by the way, that is both, what if I get hit by a bus? What kind of medical care in the hospital do I want? And what kind of care would I want if I actually decide
Survived it.
and survive it and or have a chronic illness and prefer to be at home?
Right.
Those are all forms of advanced care planning, and they're very, very critical to have. And so let me give you an example. Let's talk about the ICU kind of life prolonging treatment advanced care planning piece, right?
Yes.
What happens if you get hit by a bus? Well, again, this is these conversations have to be specific to the person, right? So if you're a completely healthy 50-year-old and you are going to get hit by a bus, I think it's a very rare person who would say, limit my care in any way. I think most people would say, let's just do everything. And I would be shocked if someone said that. Let's just go for it. Let's try to get this person back. It's when you start having more and more impediments to living the quality of life that you would find acceptable. And again, that's very, very, very personal.
Right.
There's
Right.
no objective decision about what's a life worth living and what's not a life worth living. Everyone's going to make their own choice, but everyone needs to be, those are the kinds of conversations we've got to be having with our families. What is a life worth living to you? Not like, what do you want to do if I get hit by, if you get hit by a bus, I think everyone would agree, let's try to save your life. Let's try to get you back.
Yeah. Do your best. Yes.
But the bigger and more important question is like, how do you want to live? What is important to you? What is important for you not to have? There are some people who say, if someone has to, and I've heard this, if someone has to wipe my butt,
Right.
I do not want you to do heroic measures to keep my life. That will not be, if that's the state that I'm going to be in for the rest of my life, I don't want to use heroic measures to keep me alive at all costs.
Right.
That's important information. Other people would say, I don't care if I'm physically disabled and someone has to provide total care and hygiene. That is still a life worth living to me. What would make a life not worth living for me would be if I could not think straight, recognize my family, if I was afraid all the time, etc. Those might be conditions. If I was in pain all the time and I wasn't getting good palliative care, which why wouldn't they be getting good palliative care? I don't know. So
Nobody mentioned it to them. That's why nobody mentioned it to them. Yeah.
Well, that's right.
But go ahead. Sorry.
No, I mean, I'm just saying
Yeah.
that these things, it's really about how do you want to live? What are things that would be acceptable to you? What are things that would be completely unacceptable to you? Those are the conversations that are critically important for people. And then people need to understand where they are in terms of functional status and prognosis, because if you are debilitated with end-stage lung disease and you're unable to get out of your bed and you're wearing oxygen all the time, that may be an acceptable quality of life for you. But if you're going to get intubated the next time, or if your respiratory status is going to deteriorate, you may say, I'm not willing to take the risk of continuing to use ventilators and life prolonging treatment because I probably won't get back to this place again.
Right.
I hope that makes sense. I hope I'm making sense.
Yeah, no, that makes perfect sense. And it's all subjective. And then what happens is you can have that conversation, and then, you're in the room and things aren't going well. And there's a moment of lucidity with your person,
Right,
where they change their mind.
Oh yeah, sure.
Or where you change your mind.
Yeah.
And then what?
Yeah, so this is where it gets ethically heavy and complicated. And the bioethicists of yore and yonder have really thought these things through. And what we're talking about here is we always want people to speak for themselves if they can.
Right.
And yes, people change their minds, and that's okay. We want people to be able to speak for themselves. But as we all know, that people, many people, as they get sicker or whatever their disease process is, come to a point where they can't speak for themselves. They don't have capacity. They can't make decisions for themselves that where they perceive and understand all the options in front of them and are making informed decisions. In situations like that, we look for a surrogate decision maker. Hopefully that person's been identified by the patient. So you really feel that extra level of comfort that this is the person that patient would want to have speak for them.
Right.
And then that person hopefully can channel their loved one and say, this is what she would say now. This is what she would want now. And not be thinking of their own preferences, but the patient's preferences, because by the hope would be, in the ideal world, they would have identified this person early, and then there would have been ensuing conversations around all the things that we talked about before. How do you want to live? What would be acceptable? What wouldn't be acceptable?
Right. And I mean, listen, the things that come up in the world. And I remember when Joan Rivers had that unfortunate incident happen. She had written in her will, if I can't do 35 minutes of stand-up, don't save me.
Wow, I didn't know that. Wow.
Yeah. So it's part of some useless knowledge I have here, Jessica.
Wow.
But how do you determine that? So you do have the conversation, you finally get the conversation, and then you get this abstract setting that you're going to bring to a doctor, and they're going to be like, I don't know, and it's just, doctors can only work with what they're working with. So how do you know?
Yeah. Well, you're getting to all of the most important questions. You should write a book. I'm serious. You should write a book about from the perspective of the surrogate, loved one, loving daughter, the decision maker. My book has a lot of stories around these ethically complicated situations. This is not, there's not rights and wrongs in science here. This is human decision making, and it's an imperfect science. We do the best we can. What we want to do is optimize all of the decisions for the best, to be the best situation for decision making that we can, and then we have to hope that they're the right decisions. Ultimately, you're right. Without really assertive and planned out decision making and advanced care planning, we're sometimes guessing based on things about this person and how they live their life about what they would want in this situation. And so it's, I'm trying to remember your original question.
About how do you, as doctors, because you don't you
Yeah.
kind of know what's going to happen, but you don't kind of know what's going to happen.
Yeah. I mean, I think that's the whole point. This is all about uncertainty. You see,
Yes.
doctors are very, very uncomfortable with uncertainty because one of the things, as you were watching your Grey's Anatomy, which I know you're watching now, we're supposed to look really smart all the time.
Right.
We're supposed to know. And people are like, well, what do you mean you don't know? And what do you mean you still? But the fact is, you know, medical science is also an art. And a lot of it isn't scientific, and a lot of it is based on experience. And I think this is what's likely to happen. And these are the 4 different scenarios, as I often talk to my patients and families about. There are 4 ways that this can go. It could go this way, which is our best case scenario. It can go this way, which is our worst case scenario. And there are ways in between. Let's talk about what we would want to do if we see it moving in this direction, if we see things moving in this direction, and try to have a plan for all the different what if situations that could come up. And that's why, again, we have to acknowledge the uncertainty. We have to acknowledge the fact that we don't have crystal balls in medicine. What we have is the ability, a lot of experience, a lot of patients with similar types of conditions. And so and what I would call time trial information. So we can say, as we're starting to get to know people, these are the 4 directions that things could go. Let's watch for 2 days and see if we're going in this direction, and let's keep talking. We should be having conversations with the decision makers, whether it's the patient or the family members, frequently over the course of a week as we're watching what's happening to the patient in the hospital or in the outpatient setting. We should be touching base and helping with decision making all along. And frankly, not only is that important from a medical prognosis perspective, helping people understand prognosis, it's also helpful for building trust, for making families not feel abandoned. Because if you can imagine, if people feel distrust of the healthcare system or abandoned by the healthcare system, a lot of people are going to just say, well, doc, do everything, because I don't really trust that you're here for my best interest. I feel abandoned already. So if you can really create relationships between the healthcare team and the patient's team, meaning the family members and the patient herself, you foster a relationship where there's trust, and you're much more likely to get into a truly therapeutic decision-making situation. Does that make sense?
It makes perfect sense, but when you're in the situation, you got 10 minutes here. So let me try to explain everything while they're doing this.
Yeah. Yes.
So the reality of healthcare does not play in our factor. The reality in healthcare does not play in my asking those questions. Aside from you, which I wish we could clone you and put you in every hospital across the country, trying to have these conversations with a doctor in those moments, because they are moments. And then, when you're in a hospital, especially now, oh my God, especially now, good luck. Good luck trying to get anybody. And then when you do get them, you've got 6.5 minutes because they got to go. And you're trying to make your case, and you're trying to make them understand that this is a person that I care for, that you don't know what they look like, not in this hospital. You don't know who they are. You don't know what they are.
Rosanne, beautifully said, painfully said, heartbreakingly said. And there is such a void of humanity in the healthcare system. I don't mean that people are cruel or intentionally cruel, but there isn't a lot of real connection. I was just explaining to somebody the other day what a hospitalist is, and I don't know if people on the call know what a hospitalist is, but it was in the, I guess, mid 80s or early 90s when people started saying, you know what, primary care physicians shouldn't be going into the hospital to manage their patients. It's not generating enough money. It's too inefficient. So this whole group of people called hospitalists take care of patients when they come into the hospital. So those people who have their long-standing primary care physicians on the outside, those primary care physicians aren't really even generally a part of what's happening in the hospital, and in the hospitals where crucial decisions are being made. So that's just one example of the change of our healthcare system towards less communication, less connection, less collaboration, more feelings of abandonment, more fractured care. And all I can say is, you're right. It's not adequate. It's not gearing us towards the humanity and the humane approach to caring for people in these most vulnerable times. And we've got to change it all up. We've got to change it all up.
Yeah, totally. And, I come at it from a dementia standpoint as well.
Yeah.
And when, there is always that risk of delirium. And then there's that risk of you have surgery for a heart valve replacement or for whatever. And the anesthesia then changes into dementia.
Yeah.
And sometimes I feel like the doctors don't, it's almost like they don't know.
Yeah.
And you bring it to them and they're like, oh, really? It's like,
Yeah.
wait, I'm not the doctor. You're the doctor.
Yeah.
Why do I know this? And it's not on your list of concerns.
Yeah. 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 We don't set up the healthcare system so that doctors are supported, whether both in terms of time, in terms of compensation for those types of activities of communication, in terms of not feeling like, oh, I'm a bad doctor because I'm advising to do less.
Right.
We've completely set doctors up to fail in this work, and the easiest and most, I don't mean easiest like doctors are lazy. It's just that it's so hard to witness suffering. It's so hard. And we've created this path of least resistance for these overworked doctors. And I'll tell you right now, we're really overworked.
I can only imagine.
This path of least resistance is just to, first of all, to keep treating, and then to not really connect. So I hate to, I don't want to sound like a naysayer, but the current system is not well set up. And what I feel is that we need to do, in a way, workarounds around the healthcare system outside. In 2004, I co-founded a group called Vital Decisions, which is still going. It does telephone counseling for patients with serious and life-limiting illness. And at first, we were sort of, with my colleague, Helen Blank, who's a bioethicist, we were sort of talking about, well, we really want to make sure that the physician of that patient is okay with us kind of coming into the picture and talking to the patient. And so we tried reaching out to all these doctors. Is it okay for us if we talk to your patient? Do you mind if we talk to your patient about their prognosis and helping them with decision making? None of the doctors even got back to us. So we made a decision that we were just going to bypass the doctor. We were going to call right to the patient. We're going to say, we're a service that is paid for by your insurance company, which you can imagine in 2004, 2005 was like, oh, that's a death panel.
Oh, yeah.
Do you know what percentage of people wanted to talk to us when we said
I would guess 80.
It was higher. It was around 90. Most people were like, we want to thank you, thank you, thank you, thank you. And from there on went Vital Decisions, which is now how many years old? Started in 2004, many, many years old.
That's wonderful.
It's really, it's a workaround. It's saying, we're going outside of the healthcare system. We're going outside of that hospital and that healthcare, that medical practice. And we're just going to come at the patient from this angle and say, we're here to support you. We're here to help you think through how to think about your mom and what decisions you need to make next.
Right.
And that's one workaround. There's lots and lots of workarounds, but we got to start doing them because people are suffering.
Well, they are. And another workaround that I thought of was the death doulas.
Oh.
So, I mean,
hail to the death doulas.
Totally. And I think it's a great advent, and it's a great safety net, because people have great hospice experiences and people have crappy hospice experiences, and there's not a whole lot in between.
Yes.
There's a lot of, it was fine.
Yeah.
But to actually have someone who will come and sit and be in that process, because that process is a process. And I really do feel like it's almost like giving birth.
Yes.
On the other end.
It's harder sometimes.
Yeah.
And more, in some ways, more important. I don't know. Maybe that's not fair to say, but yeah.
Well, it's so much that happens. And when you speak about the uncertainty of it all, and it is from top to bottom, but the problem that happens with end of life care is that it's final. So it's not like you can say, we're going to do this. Oops, it didn't work out the way we thought. Oh, sorry. And then here's your sack of guilt and trauma. Now, good luck to you, because you're never going to get past that. And that's not fair. It's not fair to anybody.
I think one of the important services that hospice offers is bereavement counseling and counseling following the death of the loved one. Now, is every hospice got a great, robust counseling. I don't
No.
know, but I think one of the things I will say is that it is, for many hospices, is I think one of the most important things that they offer, which is really supporting the caregiver and the surrogate decision makers and the family after the loved one dies, and really helping them to process their grief and their guilt. I mean, ideally, the guilt piece should be dealt with before the person dies, so that you're not experiencing that over the course of it.
Right.
But I really think it's so critically important that we get in there and really, really provide this more robust support, psychological support, physical support, financial support, all the things that caregivers need. Do you know how much money is going into our hospitals and institutions in this country? We have the highest GDP in the world for healthcare, doing things that, frankly, people don't want. Why do we know that? Because any of the palliative care literature, almost any conversation that you would have about end-of-life decision making results in people saying, I want less life-prolonging interventions. Right. So, we're just we've really got to sort of reassert this support and the communication and the conversations so that people get what they want, and it's going to save, frankly, let's talk about the M word. It saves a lot of money because people always want less than what our default is. And some of that money that's saved from that hospital environment, why the heck isn't it going into the home? Why are we underfunding the home?
I will never understand it. I will never understand it, especially when 70% of people polled want to die at home, yet 1 in 4 die at home. So it's like, I think those numbers are higher.
Well, the good news is there is more effort and more work to pull care into the home. I mean, first of all, there's this whole movement, hospitals at home. This is not for hospice patients. This is for people who want, doing care actually in the home, doing intensive care in the home. There's more sort of attention to the home environment as actually a good place. We don't just need to be in the hospital, and so I think there's a lot more attention, especially with COVID, into the experience of caregivers, and sort of a desire to really see caregivers as a group that needs to be supported. And there's a conversation happening in Washington right now, everybody. Your Congress people are involved in a very important conversation about how to support caregivers, how much to support caregivers. The amount of money that has been proposed has gone from $440 billion, it's down to $190 billion. Call your congressman if you think that this is an important thing that we should be doing more of.
Totally agree. The support for family caregivers, for in-home caregivers, is dismal. It's dismal. And we're trying to literally carry the person that we're caring for, while it's almost like walking into a river and you're trying to hold them up while you're going into the river. I mean, it's crazy. And trying to get doctors and interacting with doctors, it's so mind-numbing to me that this can't be fixed, that it can't be adjusted, that this is really where we are. I can't believe that this is really where we are.
Well, we're creating a whole group of secondary patients, or invisible patients. These caregivers, we know, are suffering physical. I mean, you should just look at the studies on caregivers versus non-caregivers, lipid levels, markers of inflammation. I mean, they're sicker, and they're getting sicker because of this work.
Did you want my blood work? Yeah.
Yeah, seriously, look at we know that people's blood work worsens significantly. Absolutely. We know that people are, missing, we know that employers, frankly, are spending a lot of money on higher healthcare bills for their caregiving employees. I mean, this is really causing a medical crisis for a whole group of people who wouldn't be in this type of crisis. And so the medical piece in and of itself is something that should really alarm the healthcare community and say, wait a minute, we've got to back it up here. We got to back upstream and say, these caregivers need more support, because we're creating a whole group of new patients here.
Totally. No, absolutely. And the long-term effects. Listen, I will research till my eyes fall out. I'm just going to keep researching. Yeah. And I still felt like I was on an island. And we had hospice. There was hospice, and that's great. And you call and they say, what's going on? And you explain, and they go, okay, we'll just do this. And you're like, well, that doesn't seem right. How is this right? And it feels like you are you're on an island and you're giving these medications and you're trying to control what you're seeing, but you're not sure what you're seeing because you're not the doctor.
You know,
So
yeah, every time I talked to you on the phone while your mother was still alive, I it was so hard for me to hang up because first of all, because I love you, and I think you in the midst of this profound stress that you were going through, you always had this sense of humor that I wouldn't have had. And but I would listen to what you were doing, and I thought, how do I get off the phone with this poor woman? How do I? She needs support. She needs to know what an amazing job she's doing. She needs all sorts of things. And and yes, what hospice would do with you, hospice is great, but that's the limit of what they do. They're not going to come and sit next to you and give you respite. And they do actually give you some respite if you need it, but they're not, that's, and I think it's really important that although there are some bad apple hospices, we should not demonize hospice in this,
no.
in this, assessment of what's happening to our caregivers, because hospice is there for a very important reason, and for the most part they do a fantastic job. What we need to do is support hospice, either to do more themselves or to provide services that work alongside hospice and coordinate with hospice to support the caregiver, so that there's not this profound distress. I was talking to a hospice nurse recently about Caregiver: A Love Story, because we've actually been given a grant to create a program for hospice staffs to help them to think about family caregiver burden among their clientele, to help them not feel this shame and blame, because that can be very incapacitating for the hospice workers are watching people like you, and then they've got to get to their next client, and they can't stay and help you, and they feel a lot of moral distress witnessing the caregiver suffering, and where they are not supported to themselves to help with that piece of it. And there's suffering all around, and we need to support hospice people, we need to support the caregivers, we need to support everybody to do this better.
Yeah. Yes, agreed. And what I feel like what happens after all of this is that there's always that second guessing. What did I miss?
Very
Why
common.
didn't I see this? What, all of that. And then what could I have done better?
Yeah.
But we're not, how do you help that? How do you support that? And how do you help caregivers get past that, Jessica? How do you help caregivers get past that?
Two things. There, as I said, as we talked about before earlier, one of the things is to provide them with the medical backup and support and training that they need and deserve, and not just dump the comfort thing on them and assume it's going to be okay. They need lots of support to do the medical work that they need to do. The second thing that I think that they need is a lot more ongoing psychological support. Our caregivers really, really, really need to be given the emotional and psychological support that professionals should be providing, whether it's psychologists, social workers. They should be connected to at least once a week to really sit down. How are you doing? How are you feeling? What are you worried about? So that they can decompress and process and reflect on what the things are. And I do believe that could be another element. So the physical and financial support of the family caregiver, the medical training, and then the emotional support of the family caregiver as they're going through this journey would be two things, I'd say.
That would be huge.
Yeah. Yeah.
Absolutely huge. And because you're experiencing all of this alone,
Yeah.
basically.
Totally.
And you're still trying to do the best you can for your loved one or your care partner. Now there's a lot of talk with palliative care, about having the other options, but you can't access these other options. It's like hospice. It's like when you're in the hospital and you have all these people coming in and you say, can I get a palliative consult? Well, they don't come on till 7. Like, you could get a biopsy tonight, but you can't talk to a palliative care person. If you need support in making your decision, we can't help you, but we can cut something out. Like, now.
Well said. Well said.
So
well said. Touche. That is exactly right. Yeah, palliative care is not typically, the strengths that a palliative care team brings, the communication, the support, the rubbing someone's back, the really knowing how to manage symptoms. That is just not prioritized to the same level that a biopsy or some kind of cardiac procedure or line insertion is. And so we don't have the staffing and the availability that other services have. And I agree with you 100%. To me, the most important thing, I mean, obviously, once you save and stabilize people's vital signs, is get decision support in there. Help people understand what is going on so they can make active decisions about what they want to happen.
So that is the number one thing. At the end of the day, the number one whatever plan is to have a plan.
Well, it's number 3, because number 1,
Okay.
as an ICU doctor, what I think about first is I want to make sure they're stable.
Right.
Stabilized. And that includes their vital signs and their pain levels and any symptoms. So those are the first 2 things you got to do.
Right.
Then immediately, what is the big picture? Let's make sure this family knows what's going on. Let's make sure we can all do some shared decision making together that is really going to be centered on this patient's preferences and values.
And you have great resources on your website. And I'm not just saying it because I'm talking to you. You have great resources on your website. Between the wish cards, like I've never seen those I wish cards. That's fantastic. Go Wish, sorry.
Yeah.
Which I think, did you develop them? How did they come to be?
No. They're great. They were developed by someone in the Bay Area. And my friend, a palliative care doctor named Dawn Gross, loved to use them. And so she introduced them to me. And I think they're terrific. Because it's all about what we talked about at the beginning, which is what is most important for you about how you want to live.
So how do we help those caregivers that felt like they killed their parents, or they did something that made a detrimental change in their parents? How do we help them leave that behind?
That is really that is why hospice has such a focus on post-death bereavement support of the family members, because this is a psychological support of a normal emotion that people are going to have. Witnessing 24/7 a person's demise over the course of days, weeks, months, that's very traumatic. And most people are going to need a lot of counseling. I'd say it should happen before, as I said, it should be happening before the person dies. It should be happening all along, but they're certainly going to need it after the patient dies, because this is a very, 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 it's traumatic in a lot of situations to go through. It's a trauma.
Absolutely.
It's a trauma, and you need support for that if we want a healthy society.
Well, and it's even, sometimes there's those, you give the medication and then they say, she may not wake up now. It's like, well, wait, when did that happen? Nobody mentioned this. Nobody mentioned when you give A, B, C, or D, this could happen and you might never speak to them again.
Well, two points for that. Two issues that really need to be reminded to the caregiver, which is, number one, this person is dying. The reason we're all here is because this person is dying.
Right.
Number 2, we're giving medications to assuage the physical symptoms. That's why we're giving this. We're not giving more, we're not giving less. This person is dying, and these medications will help keep them comfortable. These medications will almost definitely not hasten this person's death. When they die, they will die of their natural causes. And so it's just that constant reminder and that conversation and that reassurance and that reminder that this person is dying. This person is dying. That's why they may not wake up. It's not because you did anything wrong. It's because they're dying.
Right. The elephant in the room is death. Yeah, I got you.
Yes.
But it's just hard because you feel that responsibility, because you're responsible for everything.
Very, and that's why I think it can take years. In Caregiver, a Love Story, Rick says, I couldn't go back to work for a year and a half. I was so stressed and anxious. It shouldn't be this traumatic for a caregiver. I believe that if we had more support along the way for the caregiver, this trauma, this grief and bereavement that we have to actually provide as part of the hospice service would be mitigated significantly if people had much more support along the way.
I agree. And if they can't get it from the hospice provider that they have, where do they find it? Because the other thing about hospice is there are different groups.
Yes.
And then there's hospice houses, which
Are
exist
rare.
are rare. They're very rare. Some like the hospice that we had actually had a unit, so they would provide a week's worth of respite every 30 days, which is great. I mean, that's a great feature, but every hospice is different.
Yes.
So if they're not providing that information, where do you find that?
Well, first of all, most hospices, I believe Medicare requirements are that hospices need to offer 3 or 4 levels of care, one which is medical respite. If needed, if it, respite for the family. So that is something that you should, you need to know what you get if you sign up with a hospice.
Right.
There are certain things that you have access to that you want to make sure, that they have levels, different levels. If someone, for example, another level is called GIP, general inpatient care, where a person has unrelenting symptoms that can't be managed in the home, they need to be brought to a hospital environment where they can have this managed before they bring them back home. So there's several levels of care that every hospice, and you should know to ask if that hospice, do you have respite? Do you have GIP? Do
Right.
you have, most of what's going to happen is in the home. But
Right.
so
Right.
your
No.
question
There's just
was,
different. Each hospice has a different. They're all different. They all have different support systems and way they do it. And if you don't like the hospice that you're with,
oh
you
yes,
can switch hospices. Like you're
right,
not locked in. If you don't like the hospice nurse, you can switch hospice nurses,
right,
whatever.
right.
But
Yeah.
go ahead.
Absolutely. No, you're not locked in. You can always fire hospice. You can always de-hospice. You can come off a hospice if you don't like there, but there's many other hospices. So don't just give up on hospice if you don't like that particular hospice. The other thing is you said is, well, how do you get that psychological support if you're not going to get it from your hospice? And you know what? Some people are lucky enough to have the money to pay for extra therapy, which I think is one of the very, very important self-care things that weekly therapy, if you're able to afford it, could be a wonderful thing. I think caregiver support groups, which are around, there are a lot of caregiver support groups. People don't necessarily know about them. They can provide profound amounts of support to others, speaking to other caregivers, and just having that weekly get together. Some people will qualify for some resources that are out there if you have to frankly earn little enough to make Medicaid.
Right.
If you earn more than you can, then makes you qualified for Medicaid, like Rick did, and he didn't earn that much more, but he earned more.
Doesn't matter.
Can get a lot of these services, but for people who qualify for Medicaid, there's certain
Right.
things that are paid for that can be helpful. A lot of those are on the resources page at caregiveralovestory.com, by the way.
Okay.
But yeah, so actually that's another, my resources on jessicazitter.com are sort of, and in my book, I have a whole thick appendix about like the 6 steps for thinking about these kinds of things and making advanced care plans. But in addition, and then jessicazitter.com has a lot of advanced care planning resources, but caregiveraLoveStory.com has a lot of resources for the caregiver specifically that you should take a look at.
Of course you do. Of course you do. Because we are not invisible in your world. Which is a gift.
Not anymore.
Which is a gift for all of us. It's a gift for all of us. And I always say, if you don't have the people that can support you, find them, because we're out there. Daughterhood support groups. There's support groups. Hospitals have support groups. Alzheimer's Association has support groups. There's Facebook groups that are everything. I know if I wasn't seeing my therapist every week, I don't know how I would have made it through, because it is a shock to your system every single day, single day.
And night.
Well, listen, we didn't have any nights. It was just 24 hours.
I don't know how you did it. I don't know.
It was just a constant. So, but just to be clear, you're not killing your loved one.
No.
You're not killing them by providing them this care or these meds. You're not killing them.
Right, absolutely not. The hospice will teach you how to administer these medications in a way that is safe and that is really focused on managing symptoms, and that in and of itself does not hasten a person's death.
And if something happens because of that, it was not you, it was
their illness. The illness that they are on hospice for, which is leading towards their death anyways.
Right. Okay.
Yeah.
Okay. Is there anything you want to leave anybody with aside from planning? Is there anything that we have not touched on that you would like to touch on?
2 things.
Go ahead.
Number 1, all the caregivers out there, You're doing God's work. You're doing the most incredibly important work. I hope that on some level, even though it must be stressful and exhausting at many, many times, I hope you feel the value of what you're doing. And I hope you forgive yourselves for not, it's like being a parent, you know, you can't be, there's no perfect parents.
Yeah.
There's good enough parents. And it's the same thing for caregivers. There's no perfect caregivers. There's good enough caregivers. And so just feel good about being a good enough caregiver and do your best. And in the meantime, the second thing I want to say is we have to do more to support you. And all of you on this call, I hope you're going to pick up your phones, talk to your Congress people, think about what's going on in Washington right now as we're negotiating how much money we're going to apply towards the support of caregivers and be part of that activism as well.
Beautiful. I agree. And jessicazitter.com.
Yes.
Caregiveralovestory.com.
Right.
And on a personal note, 5 months ago today, Jessica, this very day, we spoke on the phone in the morning in my panic state of I didn't know what I was seeing. And we spoke 4 hours after my mother had died. And you provided such clarity for me and comfort and the ability to see, just the clarity in what happened. And you saved me years of beating myself up for things that were outside of my control. And I couldn't thank you enough for that. And I have no doubt that you have shared that with the people on this call today and anyone that will listen to this. So thank you. And thank you for all that you do.
Oh, Rosanne, thank you for all that you did for your mom and for all that you're doing for other caregivers now. And thank you so much for saying that. That you don't know how much that means to me.
I mean every word of it. Every word of it. So thank you. Thank you for being here today. Thank you, everybody. I hope you enjoyed our presentation.
Bye, everyone.